All right. It seems like we've had a robust influx of everyone. So thank you again for joining for today's Neonatal Hemodynamics Foundations curriculum lecture. We're excited for today. As a reminder, we want to thank our sponsor, Mallinckrodt Pharmaceuticals, who has provided unrestricted educational grant funding to allow this T&E Foundations curriculum to continue. So thank you to them. And as a reminder for those of us joining today from Canada, this foundation lecture series is a self-approved group learning activity as part of the Maintenance of Certification program from the Royal College of Physicians and Surgeons. So thank you to everyone who worked to get that approved for us. So without further ado, I'm going to go ahead and get our speakers introduced for today. As a reminder, this first part of the webinar is going to be recorded, and that will be a fantastic talk by my friend and colleague, Dr. Melanie Reyes, who's a clinical assistant professor of neonatology at the University of Michigan. She completed her residency and her fellowship at the University of Iowa, where she then also came back to complete neonatal hemodynamic training. She has a special interest in the tiny babies and the extremely premature population, as well as the BPD-PH phenotype. And she will be giving us about a 30-minute talk today on postnatal hemodynamics in twin-twin transfusion syndrome, from fetal circulation to neonatal management. And then, as a reminder, we will have that about 30 minutes of her talk, then have some time for Q&A. So please go ahead and, as you're listening today and think of questions, please put them in the chat, the Q&A, and we'll get to those at the end. And then after about 10-15 minutes of questions, we will ask our trainees and our junior faculty to go ahead and join us for our second portion, which is a case base, which is going to be led by Dr. Lauren Saucy-Gier. I'm sorry, I'm very bad with names, so if I mispronounce that, I apologize. She completed her pediatric residency at Laval University and her neonatal and perinatal medicine residency at Montreal University. She's currently completing her fellowship in the Neonatal Hemodynamics T&E program at McGill University, after which she will be joining the Neonatology Division at CHU St. Justine. So we're looking forward to this fantastic lecture and case discussion today. So go ahead, Mel, you can take it away.
Okay. Thank you, Amy, for the kind introduction. I have no conflicts to disclose. Our objectives today are to describe the hemodynamic profiles of both the donor and the recipient twins in twin-to-twin transfusion and understand the role of the fetal interventions on the postnatal physiology. We're going to work on recognizing the common postnatal hemodynamic derangements in the survivors of TTTS and integrate those principles in the targeted neonatal echocardiography for the clinical management of these babies. We also want to discuss the most common congenital heart defects that are associated with this syndrome and evaluate the role of the renin-angiotensin and aldosterone system in the recipient twin. So who and why is involved in this very distinct phenomenon? We're talking about monochorionic diamniotic twins, or MODI twins, as they are known. So about 10 to 15% of the MODI twin pregnancies are at risk of developing TTTS. And this is due to unbalanced placental vascular anastomosis. There is usually these anastomoses are formed, and you're going to find arterial anastomosis, veno-venous anastomosis, and arterial-venous anastomosis. And the mechanism, just to put it simply, is when you have a net flow that exceeds going from the donor to the recipient. The incidence is about 1 per 10,000 births. And these shared anastomoses, like I mentioned, are always present. And only some cases will develop this unbalanced flow And interestingly enough, this can happen at any time during pregnancy. So the Society for Maternal Fetal Medicine recommends close surveillance with ultrasounds for Modi twins beginning at 16 weeks of gestation and to continue every 2 weeks until delivery. If any concerns develop during this monitoring, then the surveillance ultrasounds can be done even more frequent. These anastomoses are of three kinds. So arteriovenous anastomosis, veno-venous anastomosis, and arterio-arterial anastomosis. And ultimately, it's going to be the sum of the net blood flow across these anastomosis that is going to determine the pathologic twin-to-twin transfusion syndrome, where the donor is giving more than what it receives back, and the recipient takes more than what it gives. Twins that are affected by this twin-to-twin transfusion syndrome have an increased incidence of congenital heart disease. It has been recorded up to 12 times higher than the general population. And this is due to a complex interaction. But we have hypotheses that unequal division of the inner cell mass when the embryo is divided and the disturbance of laterality and the phenotypic variability are going to play a part in this, as well as different growth of the fetal cardiac structures, which is dependent on blood flow. And of course, vascular mediators that are going to be altered in the twin-to-twin transfusion syndrome. The most common congenital heart disease in TTTS twins are ASD and VSD. The hypothesis behind it is that there is some increased ischemic necrosis due to excessive natriuretic proteins. In the recipient twin, the most common is RV outflow tract obstruction with pulmonary stenosis or even pulmonary atresia. And in the donor twin, vascular affectation in the left-sided structures. So what is happening to these twins in utero? You're going to have a donor twin that has less preload that is going to result in renal hypoperfusion and oligohydramnios. This is going to activate the renin-angiotensin system, and due to the decreased circulation, this is the baby that is going to be described as the stuck twin, with the oligohydramnios usually just stuck to the placenta. And it is associated with growth restriction. In contrast, you have a recipient twin that's going to have increased preload with the opposite, so increased renal perfusion and polyhydramnia. So in this picture, in this ultrasound up here, you can see you have a stuck twin with very little amniotic fluid around it, and you have the other twin that has a very generous pocket of amniotic fluid. These babies tend to have hypertension, cardiomegaly, and could develop heart failure and hydrops. The recipient twin is going to see all these increased preload with an absolute increase in circulating volume compared to the donor. And this is going to result in significant higher cardiac output. The recipient is also subjected to increased afterload in the form of increased resistance. And in the recipient twin, the renin system is going to be down-regulated. But the levels are as high as the donor because there is shunting of all these signals through the placenta. This explains the significant myocardial ventricular hypertrophy in the recipient that is out of proportion to just simple fluid overload. This consequence is progressive cardiomyopathy is going to result in an increase in cardiac size and a reduction in myocardial compliance. The most used staging method for the OB/GYN providers to communicate the severity of the twin-to-twin transfusion findings is the Quintero stages. This was developed in the 1990s, and it is a sonographic assessment tool for the severity of the syndrome. So in stage 1, you're going to have mostly oligohydramnios and polyhydramnios sequence. In stage 2, you have non-visualization of the fetal bladder in the donor for over an hour. That shows the worsening hypovolemia in the donor, resulting in reduced renal perfusion and no urine output or very reduced urine output. And this is this shows that there's now failure of compensatory mechanisms. Stage 3 is going to show abnormal Doppler indices in the recipient or donor, with at least absence of reverse and diastolic flow in the umbilical artery, reverse flow in the ductus venosus during atrial contraction, what is known as the negative A wave, and a pulsatile flow in the umbilical vein. This advanced hemodynamic decompensation reflects that now there is cardiac dysfunction, and the elevated central venous pressure can impair placental and systemic circulation. And this is a strong predictor of adverse outcomes if there's no intervention. Stage 4 is when there is hydrops in one or both fetuses. And this is more a signal of end-stage cardiovascular failure and inability to maintain oncotic and hydrostatic balance. Severe ventricular dysfunction or venous congestion are more commonly seen in the recipient. And then stage 5, which is the more advanced and terminal stage, is when we see single or dual fetal demise. Even if there's only one fetus that has passed away, there's a high risk of neurological injury or demise in the surviving co-twin due to the hemodynamic shifts. So what are we going to see in the fetal echo findings? We will see a donor twin that has decreased preload and small cardiac chambers and an aortic arch, usually with preserved systolic function, absent or reversed end diastolic flow, and mild ventricular hypertrophy. In contrast, the recipient twin, like we said before, has cardiomegaly, more prominent right ventricular hypertrophy with diastolic dysfunction, AV valve regurgitation, and RV outflow tract obstruction. So just to get in a little bit more detail, the fetal echo in the recipient is going to show AV Doppler flow that shows TR and MR. The TR tends not to be severe compared to the MR that it's severe if it's present. Elevated myocardial performance index. The M mode is going to show decreased systolic function. The EA ratio is going to show, it's going to be low with decreased compliance, and RV hypertrophy that could be associated with pulmonary stenosis or pulmonary atresia. The donor is less likely to have tricuspid regurgitation, but could be present up to 3%. The myocardial performance index is also going to be low. It's also going to show decreased systolic function, although less than compared to the recipient twin. The UA Doppler is going to show absent or reverse end diastolic flow. And if there is abnormality in the ductus venosus and umbilical vein, it's less than compared to the recipient twin, about 5 to 10%. It's abnormal. And the associated congenital heart disease tends to be a hypoplastic arch. The prenatal intervention and the gold standard now is fetoscopic laser photocoagulation. And this is a selective ablation of the placental AV anastomosis, and it can happen between 16 and 26 weeks. Amnio reduction is just a temporizing measure. It just reduces the polyhydramnios in the recipient twins. The complication of these interventions is increased PPROM, preterm delivery, amniotic leakage, vaginal bleeding, abruption of the placenta, and any intervention infections, so chorioamnionitis. What is really important for us to know is that there is a hormonal lag. So despite you sapping all those AV communications, there's going to be a continued elevated level of renin, angiotensin, and aldosterone system and the mediators. And this is going to continue for 6 to 8 weeks. So it's going to take a little bit to normalize. And you can see this effect in this sequence of the twins where they have anemia polycythemia sequence, and after they got laser, the flow in the medial cerebral artery takes several weeks to normalize. So what we expect after laser photocoagulation in the recipient would be normalization of the cardiac size, decrease of AV regurgitation, and normalization of the ventricular inflow patterns. And in most cases, there will be resolution of the cardiac dysfunction, and even high drops will resolve, but it will take time. Some babies may still have RV, outflow tract obstruction physiology, and pulmonary stenosis at the time of birth, depending on how severe it was before the laser took effect. And in the donor, we expect an acute relative hypervolemia and increased afterload. So these donor twins can have a transient worsening heart function, dilation and IV regurgitation, and even transient high drops until this gets corrected. So what is the sequence of events? We know that the right ventricular tract obstruction in the recipient is secondary to RV myocardial hypertrophy, reduced RV function with high systemic pressures, and the inability of the RV to generate enough pressure to open the pulmonary valve. So this is going to have muscular subvalvular and valvar RV-OT obstruction. And this is also going to promote remodeling in the pulmonary circulation, which is important to know for what these babies can do after birth. The coarctation in the aorta of the donor is secondary to high placental resistance, this relative hypovolemia that the donor has, and decreased flow to the arch that is going to result in evolving hypoplasia or coarctation. So what happens after birth? The clinical picture that we are all used to remember is that the recipient is going to be usually have higher birth weight, is going to appear plethoric. In contrast, the donor is going to appear pale. And the recipient can be hydropic and hypertensive, where the donor is usually hypotensive and tachycardic. The recipient twin transition, we have to remember that the baby was exposed to chronic intrauterine hypertension, and we call vascular intoxication, and it's at high risk of PPHN for that remodeling that I mentioned before. So they usually have markedly elevated systolic blood pressure in the first few hours after birth, but then an abrupt hypotension and systolic dysfunction with low cardiac output. And if these babies are born premature after the fetoscopic interventions, remember the hormonal lag, so there may not be enough time for those alterations to resolve. The donor twin has more of a vascular pathology where there's decreased vascular compliance and structural lesions like aortic coarctation or arch hypoplasia. These babies have chronic renal hypoperfusion, and the abrupt interruption of the chronic shunting when the baby is born or at the fetal intervention with the laser, it's going to have this transient fluid overload and high drops. These babies are at high risk of ischemic or hemorrhagic brain injury from all these fluid shifts. So when we are approaching the recipient twin, we have to remember that the most likely physiology and how do we want to approach it. So remembering that these babies are at very high risk of myocardial hypertrophy and critical pulmonary stenosis or pulmonary atresia and PPHN, as well as systolic dysfunction. So the characteristic progression of these babies usually is chronic volume overload. The hypertension triggers the hypertrophy and the systolic dysfunction, and this can progress to systolic failure. And the best way is to do early echo for accurate hemodynamic assessment. It's just repeating what I just said, so I'm going to skip it. The management is going to be to reduce the afterload of the affected ventricle with optimizing lung recruitment, support the myocardial function, try to preserve the preload and minimize tachycardia. In the case of RV-OT obstruction, we want to have PGE available. And in the donor twin, we have the vascular pathology with chronic hypovolemia, possible chronic anemia. So these babies have seen a low preload state with mild systolic dysfunction, and not remembering that they may have coarctation of the aorta. Also, if they have IUGR, they are likely to present with PPHN physiology. Again, for the donor twin, same hemodynamic goals: restore the preload, improve the oxygen delivery. We want to be cautious with volume resuscitation, and we want to support blood pressure, cardiac output, and renal function. And in their case, also, if we're concerned about aortic stenosis or hypoplasia, have PGE available. So just to summarize, TTTS is a placental vascular disease that has two opposite cardiovascular phenotypes. Intrauterine remodeling will persist postnatally and will persist 6 to 8 weeks from the fetal intervention. And neonatal echo is going to be critical in both twins to define the physiology and to have precise management. That is all I have.
Thank you, Mel. I'll remind everyone to go ahead and put your questions and comments in the Q&A. We'll have some time now to chat about those and ask our panel or ask our presenter today any questions. Mel, my first question while we kind of get things going is, when we're taking care of these patients after they're born, it always seems like people are worried about that donor twin because they're the smallest, they're tiny. And so inevitably we feel like they're the sicker baby. But it feels like a lot of times then that recipient twin sometimes gets ignored. And so I wondered if you just wanted to speak a little bit about some of the concerns we really see in just, I'll say, neonatal management of the donor and the twin, or donor and recipient post-delivery.
Yeah, you're absolutely right. The fact that the recipient has this appearance of better size, better even color usually than the donor makes them give you this false reassurance. And it really, they both are really at risk of just falling apart. But when you take away for the recipient the donor that has been supplying him with all that extra blood, it's a very severe change in hemodynamics for them. So the abrupt decreased preload combined to all those remodeling and the hypertrophy, it can make the baby be really sick, as well as have that PPHN physiology or pulmonary hypertension physiology. That they, I think the best thing is to get early hemodynamic echoes in the baby so that you don't have to guess what's happening and you can anticipate to the changes. We definitely have seen babies, especially the recipient baby, being given the thumbs up initially because they tend to have good blood pressures for a few hours before they become significantly hypotensive, and then you have to rush to tend to them. So I think anticipating to that with good echoes for them is probably the best management.
Great, thank you. One of the questions from the audience, they say, well presented, thank you. Could you explain the hormonal lag that is seen and also the risk of PVL that changes based post-delivery?
Yeah, the hormonal lag. So the donor is going to have everything upregulated. And so removing the communication is not necessarily going to get rid of all the hormones that are already circulating in the recipient. It takes a few weeks for those to go away. And the PVL in the PVL changes are also related to the changes in preload and afterload that these babies see, especially when you remove the other circuit from the placenta or one of the babies dies, as well as all the inflammatory markers that are circulating.
Great. Another kind of thought when I think about babies being taken care of with twin transfusion is, can you talk about why we typically see these hemodynamic effects when these babies are born earlier, as opposed to usually it seems like even those with pretty significant twin transfusion in utero who can make it, I'll say 34 or 35 weeks, what the physiologic reason why we tend to see that be more pronounced when they're born more premature?
I don't know what you're referring to.
I guess, are there things with the premature myocardium that they make them more susceptible?
Okay, yes. So that's a great point, especially when we're thinking about the babies that receive an intervention that are going to make them at risk of PPROM and being delivered premature. So thanks, Amy, for bringing that up. Since the premature myocardium is more fibrous and has less adaptability and less reserve, I think that is also why specifically the babies can't adapt as well to the changes in preload and afterload. I think also to remember that the recruitment of the lungs plays a significant factor in decreasing the afterload, especially for the babies that have RVOT, obstruction physiology. So you may see a baby that is blue and you may think it's all related to lungs, and it could be that it's actually more of a fixed defect. And so that's why getting that early echo can remove all that guesswork so that you can target the management more specifically.
Yeah, as we know that preterm myocardium really does not adapt well to those, changes in afterload. I kind of sometimes liken some of these, especially in terms of the recipient, to the post-ligation syndrome kind of, and have some similar overlaps there. Another question from our audience is, I'm not aware of this, maybe you are. Aside from clinical studies, do you know of any experimental models to study twin fetuses in order to better understand the pathways involved in order to help develop new interventions or treatments?
I am not aware of extra studies. That would be really interesting to see, especially in like animal models, but unfortunately now, not at the moment.
Yeah, like I said, I'm not sure. That, like you said, it's an interesting question there. Along the kind of lines of one of their questions, so I'm going to kind of change it just slightly. So, do we expect the myocardium hypertrophy to improve over time? And kind of as a offshoot of that, is this a patient population that we need to get long-term follow-up on? Is this a patient population that, we really need to get potentially our pediatric cardiology colleagues involved to make sure that these changes we see are resolving over time? We talk about our infants of a diabetic mothers, if they're on the severe side, being followed, longer term by cardiology. So interested to hear your thoughts on that.
We do here. So we expect the myocardium to continue to adapt around it. So if the conditions have changed for the twin, it's not like the hypertrophy goes away, but the rest of the heart adapts. But it may take several months. So we do involve our cardiologists here at Michigan in the follow-up of these babies. They like to see them prior to discharge, and they like to see them at 6 months and then a year. they have told me that it's very variable when the hypertrophy improves. And of course, it depends on any other pathophysiology or any other pathologies that they have that are giving play to that hemodynamic changes that the baby see.
I think that's fantastic. We always worry that these patients are followed really so closely when they're in the hospital, and we just assume after they go home, things are going to continue, that are going to improve. But, as we've learned with the long-term cardiovascular follow-up research that's been done looking at just our preterm babies, like we are seeing, later in life complications as a result of being preterm. And I'm happy to hear that we're at least starting that conversation with following these patients kind of on the shorter term. But I would be interested to see what does this have an effect longer term on them, even if they have like a relatively normal newborn course. I think a couple more questions, another one from the audience, and then Gabriel has a question for you too. So from the audience, it says, we're moving away from partial exchange. Is there any fluid management strategies, and would follow-up on T&E help manage these babies, in particular with the recipient twin?
Yeah, I think in the case of these babies, the best way is to do individualized management. So do early echo assessment, and then if we're talking about a baby, specifically the recipient team, we normally are not too worried that their preload is low. Focus on trying to overcome the RVOT obstruction if there's one, making sure we're not making any or having any interventions that are going to affect that physiology, like tachycardia, trying to reduce the afterload for that right ventricle, and follow up after the intervention. I think it's the best strategy.
Great. Gabriel, do you want to ask your question, or would you like me to read your chat?
No, I can ask. Thanks, Mel. That was really a splendid review. It's a very complex physiology, and I feel like I learn each time I hear experts share their thoughts on it. I was wondering, we have seen a few cases of these very significant, there's multiple probably collateral vessels, and then we end up doing a laser, which is, of course, at the surface of the membranes on the fetal side. And then there are recruitable collaterals within the placental circulation that makes that there's sometimes even shifts, and we start seeing like a reverse donor to recipient sequence, where the donor becomes a recipient and the recipient becomes a donor, and the Doppler starts behaving abnormally again. I'm just wondering, I think there's very scarce literature, but I'm sure you are probably the most updated from all of us. Have you seen anything on that? Have you seen any cases in your practice? Is there particular elements we should be looking at for these babies after birth? Or kind of, is it still the bulk of their hemodynamic picture, the part from like their pre-laser kind of physiology, which has been the longer term physiology?
Yeah, that's a really, really great point, because we do see this phenomenon, which then has everyone scratching their heads. And I think a lot of the times when we see this transfer, at least in the cases that I've seen here, we have the OVs then questioning the best time for delivery for the babies. And in my experience and what I've read, I think it is the physiology that the baby had been exposed to the longest that is going to be the one that you end up seeing at birth or after birth. So if a baby was predominantly the recipient for most of the pathology course, even if he had switched for a short period of time and then delivered, he's still going to behave like the recipient because he has the structural changes.
Yeah, it's fascinating. And I think there's more questions, but I'll ask one other and I promise I'll I was wondering in your practice or in some of the practice that you've joined, are there specific protocols of like when should these babies be assessed? And I'm thinking mostly, of course, those who were the sickest that we had to deliver preterm because either failed laser or, hydropic picture. Do you have like a kind of protocol where you do at birth and then you follow them at specific time points, 36 weeks, or is it really depending on their clinical manifestation, I would say? Thank you.
We currently don't have a protocol for twins. They are mostly followed closely if they are born premature because they fall on the protocol for the extremely premature babies or the babies that we're following PDAs for. But if after they are diagnosed with if they have heart failure or they have ventricular dysfunction, then the follow-up is more determined on that and the management, and not necessarily because of the twin-to-twin or the prematurity. The ones that we still have to create a protocol for are the babies that are more like late preterm that have twin-to-twin. Those are the ones that unfortunately are not followed closely usually, and the ones that end up becoming really sick.
Gabriel, what do you guys do at McGill?
Yeah, what do you guys do?
Yeah, we agreed with our cardiology division that regardless, they would need like at least one evaluation at birth. So all of them get evaluated at birth, regardless of gestational age. So some of them will be born closer to term, will go to the nursery, and often, the primary will be, of course, cardiology who will see them. If they're admitted in the NICU, we might be asked very early after birth, depending on their instability. It's a shared kind of mission, but the agreement is that all of patients who are born with TTTS physiology and fetal life needs to have at least one echo before discharge, mostly because we don't want to get fooled about missing RVOT obstruction as been outlined by Melanie, and because some of them may have significant hypertrophy and unrecognized hemodynamic compromise. And we've surprisingly been, one case that I can remember was preterm 24 weeks who had nice juicy PDA at birth and looked like to have a very benign initial picture. And of course, by the time we got to 36 weeks, people were like, oh, there's a murmur, it's the PDA closing, the baby is fine. And then we come to do a PH screen and there was like super severe RVOT obstruction. We had to, I called my friend in cardiology. Actually, my friend cardiology was like seeing a CHD kid in the unit. I'm like, can you come here? So the next day this kid was going to the cath. And I think we have to remind ourselves when the duct is wide open, you can possibly mask some of these RVOT obstruction, especially early in life when the PVR is still high and there's just not that much velocity through the outflow tract. So you can kind of not see as how the gradient could be severe through the pulmonary valve. So just to keep in mind for our audience, if they have TTTS patients, I think in their unit, my feeling is that they should all have an echo before discharge, but I'm obviously very biased in that way.
Remember the scary cases.
Yeah, it's interesting you bring that up, Gabriel. We had similar cases where I think they were like 27-week twins who we treated their PDA in the beginning and had a little bit of a gradient across their pulmonary valve, but as we know, those gradients can progress over time. And I think those are really great examples of like shared care then between cardiology and hemodynamics, because it's also like, well, if the PDA came back and it was like, well, do we try to close it again? Do we need it open? Is this going to progress? And so I think we had really nice, robust conversations between them. And we at Iowa we screen a lot of babies, obviously, because of our PDA screening. So anyone born less than 30 weeks already gets enrolled. But then we are in the process of rolling out a formal formal screen for the twin transfusion babies that do make it to the NICU, in terms of those that are in, like the step down units and are, those 33 weekers just on a little CPAP. And it's like, do we screen those? What do we do if we find something? Because if they're asymptomatic from it, is this something that they're just going to transition through? Is it going to be a problem? So I think it's really easy to know what to do with easier to know what to do with the extreme preterms. But what do you do with those that are kind of subclinical? And we also see a lot of times where they might not get the official diagnosis of twin transfusion from OB, but after they're born, you're very much like, this feels like it, and how they are acting from a hemodynamic standpoint, from a hematologic standpoint. So I think it's another kind of just barrier in this whole topic of, just because they haven't been diagnosed prenatally doesn't mean they don't have it postnatally. So,
right. And it can develop at any time.
Yes.
Like if you weren't looking.
Yes. I think we'll do one last question before we switch over to the case. And then kind of a question of, this does come up sometimes. Melanie, in your research for this talk, do you know of any hemodynamic differences that we see between twin transfusion and TAPS?
Yeah. So the twin transfusion syndrome, it's more volume that is exchanged versus in TAPS, it's not so much volume. So the baby are going to have a high reticulocyte count in the donor, indicating more of a long chronic process where the hemodynamic changes are not as severe compared to the twin transfusion syndrome.
And then we had one last question. I think we kind of touched on this real quick, but the question was, do these babies need to be followed up in cardiology clinic with echo for pulmonary stenosis? And it sounds like we've talked, like, if there's any prenatal or postnatal concern, it's always better to have cardiology to at least check in and make sure that things are progressing as normally. Would you agree?
Yeah, we've decided that any baby that we're concerned gets a prior to going home echo, and kind of follow from there. But yeah, we're just talking about this could be missed in if they are otherwise acting okay.
Yeah. Perfect. All right. Well, I'd like to take a moment to remind everyone to go ahead and remember, please take a moment to fill out an evaluation for this session. Lots of great conversation that we had. And thank you, Dr. Reyes, for your wonderful talk and your Q&A today. And as a reminder to our trainees and junior faculty, please go ahead and click through to the case review session for another robust discussion. So, and as a reminder, our next session is a little off cycle, but is a really exciting one. In the middle of May, I think May 13th, Dr. McNamara is going to be talking about future directions of hemodynamics. So we'll see you then. And we'll see everyone over in the case review.